How does a nurse's perspective or how they interact with patients influence what kind of research they do compared to someone else?
You may have realized or noticed that early nursing research was very qualitative. So nursing research now runs the gamut from very biological all the way to much more sociological, qualitative types of research. What I see is nurses really understand patients. They understand the problems that they have, the difficulties in getting through daily life with whatever problem they have. And if they bring that to their research, it's usually in a very fundamental clinical way. And how can we develop an intervention on a basic science level? And that's actually why I was drawn toward yoga, because yoga has a very physiological basis. Yoga is helpful because it seems to not only help your muscles and various forms of physical function, but I think there are parts that help your soul and parts that help your autonomic nervous system in ways that may not be obvious with other forms of exercise. So I do think there is something special about yoga.
And that those unique factors are what contributed to you choosing it for your study versus a different form of movement?
That's right.
So it seems like the studies are evolving from patients self-reporting to actually gathering these statistics. And I'm wondering if those kind of lifestyle markers are still remaining in the studies as they go on, or if it's mainly gearing towards these more clinical statistics now.
The endpoints that they're looking at are things like sleep, fatigue, but those are things that are pretty particular to cancer patients, especially as they go through chemo.
What will be the clinical markers that you use in your research?
So that's a great question. So the NIH doesn't want to, sadly, fund something that makes somebody feel better, but they want to fund things that improve mortality, decrease rehospitalizations, and improve clinical markers. Our primary measure is physical function. In Durant's study and in my study, physical function improved after yoga in both our pilots. The other thing that we would like to look at as well is hospitalizations and mortality. We can look at cost. So that's another important issue. So if people don't go to the emergency room, if they take their medications and are adherent, those are other markers that you can look at. And then we're also looking at symptoms. Imagine if I'm in a room of cardiologists and I start talking about yoga, probably 98% of them are going to shut off in 60 seconds. So if I'm going to get their attention, I have to talk about something that affects the patient's physiological function. And if I start talking about the autonomic nervous system and heart rate variability and its influences on mortality, then I'm going to capture their attention.
Remember that cortisol was one of those markers, so is that something that you guys would be looking at in your study as well?
Actually, that's a great question. We thought about doing that, but you know what the best measure really of stress is the heart rate variability. Stress is influenced by, or stress influences the autonomic nervous system. The autonomic nervous system has the parasympathetic and sympathetic arms. For people who are fit and healthy, they have their heart switch back and forth between the parasympathetic and the sympathetic nervous systems all the time. And when you're asleep, your parasympathetic nervous system is more prominent than the sympathetic nervous system. And that's true in the reverse when you're driving to work or you're at work and seeing patients. So the sympathetic is engaged. Those aspects such as sleep and autonomic nervous system function and stress are all related to your autonomic nervous system function.
And so the heart rate variability is something that could be measured in other patients that aren't dealing with cardiac issues as well as a marker.
That's right. That's exactly right. Heart rate variability is something you can measure in every single person. And you put a Holter monitor onto a person and you can measure their heart rate variability. We put Holter monitors on all of our subjects, and their heart rate variability improved in every single one of them. So that, as I mentioned before, heart rate variability is linked to mortality. If you have poor heart rate variability, you are more likely to die.
There's a place called Memorial Sloan Kettering in New York and MD Anderson in Houston that have in-house complementary centers now. What do you think's driving the trend? Do you think it's consumer demand? Do you think it's research validating that these things actually work? Do you think it's desire to keep those profits in-house?
I think it's all of those things that you mentioned. There's certainly public demand, and I think it definitely arose from the cancer and also chronic pain patients. There is also a growing group of investigators and researchers that are very interested in finding ways to make people on a very basic level feel better. Certainly they want to attach hard science to it, and so you can't, you need to add the credibility to it.
With this demand, how do you think it'll change the scope of nursing practice?
Nurses always think about complementary therapies. They have since nursing began. And I think it's because they always think about the whole person, and they're very scrappy. They want to think about different ways. There might be cost issues. There might be things, nurses hold people's hands during procedures. That's a complementary therapy to help them, emotionally, and to help them with pain issues in going through a procedure. Nurses always reach toward those things because they know that there are different effective ways to make people feel better.